In this chapter, we're going to concentrate on central serous choroidopathy in the older population, meaning the population greater than 50 years of age. This problem can be challenging for a variety of reasons. First, central serous is generally considered a disease of younger males under stress and maybe a type A personality. However, up to 50% of cases may occur in the older population, and the male-female ratio is more 1-to-1 than 4-to-1. Most often, we see subretinal fluid in a patient who is 50 or even maybe 70 years of age, and the first thing we think about is neovascular macular degeneration. And to make things even more complex, even after careful and correct diagnosis, choroidal neovascularization may develop in older patients with central serous years after their initial presentation. Another problem we have in reporting on central serous in patients over 50 is the lack, paucity, and quality of clinical studies that look at this particular problem. In 2020, Adrian et al. Reported a retrospective study of 1 year of their retina patients. They found that 2% of their patients who had a diagnosis of neovascular macular degeneration actually had central serous choroidopathy. However, their initial diagnosis of macular degeneration was made from fluorescein angiography and SD-OCT. The diagnosis of central serous was made if there's no clinical response to anti-VEGF treatment after only 3 months. They did not perform an OCTA, and we will see later why this is so important. Dr. Spade and his group reviewed a consecutive series of 130 patients referred to their practice with a diagnosis of central serous. Of those 130 patients, 32 were older than 50 years of age. That again puts it more, that half the patients were over 50. While 25% were referred with the diagnosis of wet AMD, only 10 of those 32 had a choroidal neovascular membrane documented on their testing. During the follow-up period, an additional 3 of the 62 developed a choroidal neovascular membrane, and this was done with fluorescein angiography. So first, just a super quick review of the classic central serous. Typically male, under stress, a history of steroid use, ages 18 to 45, clinically monocular, although half the people will have bilateral disease when studied with fluorescein angiography or indocyanine green angiography. The demographics of the older population is different from the younger population with central serous. In the older population, there is less of a gender bias, and the male to female ratio is almost 1-to-1. While the presenting vision is fairly good in the younger population, it is less so in the older population. The disease is more likely to be bilateral in the older population, chronic, and it also does not respond well to treatment. Again, adding to the complexity of making a proper diagnosis in central serous in the older population, there are some OCT findings that can be very confusing. First, we all know of the double layer sign, and this supposedly is a sign of choroidal neovascularization. However, OCTA confirmed non-neovascular AMD. The double layer sign is present in 60% of the patients over 50. Also, due to the chronicity of older central serous, there is rupture of the ellipsoid zone in 70% and also subretinal fibrin in 33%. The outer nuclear layer can also be thinned. So let's go through some examples from my practice showing you the difficulty in this particular problem. Here is a 77-year-old woman who had had 3 injections for neovascular macular degeneration prior to coming into the office. She noted a gray spot and the vision was 20/30. She had clinically subretinal fluid and an irregular RPE layer. She then received 2 more injections and then was lost to follow-up. Here is another example of a 74-year-old female. She'd had a blurred spot in the right eye, which did not improve with glasses. Her vision was 20/25. Again, the OCT shows subretinal fluid, elongation of the photoreceptors. There's no intraretinal fluid. The differential that was discussed with her was central serous, occult choroidal neovascular membrane, and she was begun on a trial of anti-VEGF injections. I saw her for the first time 3 years later. She was still on monthly anti-VEGF treatment, and her vision was remaining at about 20/25. If you look at the color photographs, there's very little sign of macular degeneration. She does have a few drusen in the supratemporal macula, and there's no pigment migration, no hemorrhaging, and no fluid. The red-free photograph on the right is also fairly normal. The early phase of the fluorescein angiogram on the left shows maybe just half a hair of some hyperfluorescence near the fovea, and the later phase of the angiogram does show some diffuse hyperfluorescence around the fovea. Now, if you go back to our discussion of occult choroidal neovascular membranes, this indeed, on the angiogram, could be an occult net, but you would need a OCTA to make a proper diagnosis. Well, an OCT and OCTA were performed. The OCT shows the subretinal fluid, elongated photoreceptors, as you've seen in other cases, but the OCTA does not demonstrate a choroidal neovascular membrane. Here is another example of a patient over 50 years of age. He had had blurred vision to the level of 20/40 for 5 years. The OCT shows subretinal fluid and a very small double layer sign. The color photograph was taken 4 years later, and you can see some mild RPE changes just superior to the fovea, but there are no hemorrhaging. The vision was stable, and this patient had had no treatments during that 5 years. And here's the fluorescein angiogram of that patient. You can see in the early phase, there's some hyperfluorescence and some hypo in the central 1-disc diameter centered on the fovea. There may possibly be some hyperfluorescence also in the inferior macula. The late phase, the black arrow shows increasing fluorescence centrally, and the white arrow points to what is most likely hyperfluorescence secondary to a gutter sign inferiorly. And here is the patient's OCTA, and it confirms that even though there's fluid, there is no choroidal neovascular membrane. A repeat OCTA was done 5 years later because her vision had declined from 20/40 to 20/60. She still has the subretinal fluid, but the OCTA does not show a well-defined net in the choriocapillaris. Now, here we are 10 years after her initial presentation. Her vision is still at 20/60, but look now at the OCTA. She has a very well-defined choroidal neovascular membrane under the double layer sign, although the flow portion of the OCTA does not show a lot of flow in the membrane. Now, for our last example, here's a 70-year-old who had had variable vision for 4 years, and she was using Flonase. The color photograph does not show any drusen or any other signs of macular degeneration. The fluorescein angiogram again shows some diffuse hyperfluorescence just superior to the fovea and maybe a little infratemporal to the fovea. And the OCT shows subretinal fluid. The diagnosis should be chronic central serous with given that diagnosis and the clinical picture. However, here is her OCTA, and you can see a very well-developed choroidal neovascular membrane under the double layer sign, and also in the outer retina. So even though historically and clinically she should be central serous choroidopathy in the older population, the OCTA makes the correct diagnosis of neovascular macular degeneration. So, in summary, up to 50% of patients with chronic central serous may occur in patients over the age of 50. There are more diffuse RPE changes, and that also makes them more prone to develop choroidal neovascularization. According to Dr. Spade and his practice, almost 10% of patients had a choroidal neovascular membrane on initial presentation, and another 5% converted during his follow-up. In trying to differentiate chronic central serous in the older population from neovascular macular degeneration can be difficult, especially if you only rely on OCT and fluorescein angiography. This is because both of these disease processes may have similar OCT findings. The double layer sign is present in chronic central serous in the older population 60% of the time, ruptured ellipsoid zones in 70%, and even subretinal fibrin in 33%. Because of the chronicity of the fluid, there are many RPE changes and window defects in chronic central serous, and therefore there may be similar hyperfluorescent findings on fluorescein angiography as there are in neovascular age-related macular degeneration. So, if you find subretinal fluid in a patient over 50, do not assume that automatically that is secondary to neovascular age-related macular degeneration, because you can be fooled both with OCT and fluorescein angiography. It is necessary to get an OCTA to differentiate between those two different conditions.